Hello. Thank you all for being here today. I want to invite us into a broader conversation about maternal and child health, one that stretches beyond the clinic, beyond the hospital, beyond the university and research centers, and even beyond traditional public health. My name is Dr. Mariah Cedar. I'm an assistant professor of One Health at the Center for One Health Research at the University of Alaska Fairbanks. And we're going to look at maternal and child health through a One Health lens. Now, when many people hear One Health, they think and know about zoonotic diseases, animal health, or environmental hazards. And that's true, those are all core parts of One Health. But I want to explore with you today is this. What happens when we bring maternal and child health into that conversation, not as an afterthought, but as a central focus? My goal the next 30 minutes or so is not to give you all the answers, but to open a door, to invite you to see your own work, your own discipline, your own commitments inside a larger interconnected system that shapes pregnancy, birth, and early childhood. I want to begin by naming my positionality in this work. I come to One Health through the doorway of maternal and child health, and specifically through my research on how climate change, disasters, and extreme weather shape maternity care. My work has been deeply informed by doulas, midwives, and birth workers, people who often see first how environmental disruptions affect pregnancy and birth long before those impacts show up on data sets or policy briefs. I approach this work as someone committed to reproductive justice, community knowledge, and equity. I see maternal and child health as a space where environmental, social, and structural forces collide, and where the consequences are often borne by those with the least power and the fewest resources. I want to acknowledge that my work is interdisciplinary and increasingly transdisciplinary. I collaborate with clinicians, environmental scientists, public health practitioners, community organizations, tribal organizations, and birth workers. That collaboration shapes how I understand One Health, not as a technical framework, but as a lived reality for families navigating climate, environment, and care systems every day. So I share this not just as a researcher, but as someone who believes that centering maternal and child health in One Health is essential for building healthier, more resilient communities. Let's start with the basics. Maternal and child health, MCH for short, is about the health of women, birthing people, infants, and children across the life course. It's often described as a cornerstone of public health, and for good reason. If you want to understand the health of a population, always look at how mothers and children are doing. But maternal and child health is also a mirror. It reflects the conditions people live in, access to quality care, exposure to environmental hazards, social and economic inequities, and the strength or fragility of our systems. Globally, we still see unacceptably high maternal mortality in many regions. We see stark disparities by race, class, geography, and migration status. We see children facing rising burdens of respiratory disease, developmental challenges, infectious diseases, and climate-related health impacts. So MCH is not a niche topic. It's a lens on justice, on systems, and on the future. Now, why bring One Health into this? One Health, as many of you know, is a framework that recognizes the interconnectedness of human health, animal health, and environmental health. It asks us to see health not as something that happens only in bodies, but as something that emerges from relationships between people, between animals, between ecosystems, infrastructure, and climate. Traditionally, One Health has been used to address things like zoonotic diseases, food safety, antimicrobial resistance, and environmental hazards. But if we pause and think about who is most vulnerable in these systems, maternal and child health immediately comes into focus. Pregnant people and young children are often the first to feel the impacts of environmental disruption. Let me give you a few examples. For heat exposure, there's increasing evidence that links extreme heat to higher risks of preterm birth and other adverse pregnancy outcomes. For air pollution, exposure to fine particle matter has been associated with low birth rate, stillbirth, and respiratory problems in infants and children. Water quality. Contaminated water can affect pregnancy, breastfeeding safety, and infant health. Vector-borne diseases, conditions like Zika and malaria, have profound implications for pregnancy and child development. When we look at these issues through a One Health lens, we see that maternal and child health is not just about prenatal visits or delivery care. It's about climate, land use, housing, transportation, agriculture, and emergency response, excuse me. It's about the ecosystems we live in and the systems we've built. I want to briefly define four terms: unidisciplinary, multidisciplinary, interdisciplinary, and transdisciplinary. As I go through them, I'd like you to think about where you would place your own work right now. Unidisciplinary, this is when we work within a single discipline, using its tools, method, and language. For example, an OB studying preterm birth solely through clinical risk factors such as blood pressure, infections, prior history, without bringing in environmental or social data. The work is valuable, but it's bounded by one field. Multidisciplinary, here multiple disciplines are involved, but they work in parallel rather than truly integrating. Imagine a project where a pediatrician, an environmental scientist, and a social worker each contribute their own piece. One looks at child health outcomes, one measures air pollution, one assesses family stress. The pieces sit side by side, but they don't fully merge into a shared framework. Interdisciplinary, this is where disciplines begin to integrate. Methods, concepts, and data are combined to answer shared questions. For example, a study that links environmental exposure data with maternal health outcomes using both epidemiological methods and environmental modeling and interpreting the results together. Transdisciplinary work goes a step further. It doesn't just combine disciplines, it creates new shared frameworks that can't be easily placed inside one single field. And crucially, it often includes community knowledge and lived experiences as central, not peripheral. Think of a project where birth workers, climate scientists, epidemiologists, urban planners, and community leaders co-create a model of maternal resilience in the face of climate change. The knowledge that emerges doesn't belong to just one discipline. It's something new. Now, I'd like to pause for a moment and ask you to reflect. If you had to choose, where would you place your current work in one of these four approaches? And if you could move one step along that spectrum, what would that start to look like? The reason this matters is that One Health, at its best, is inherently transdisciplinary, and maternal and child health, when we take it seriously, demands that kind of approach. Let's apply this One Health lens more concretely and think about risk. When we talk about risk in maternal and child health, we often focus on individual level factors such as age, medical history, and behaviors. But a One Health perspective pushes us to map risks across multiple domains. Let's walk through a simple One Health risk analysis for maternal and child health. Thanks to AI, we have this image, and we're going to start with human health risk. These are the outcomes we usually track: So things like maternal morbidity and mortality, preterm birth and low birth weight, hypertensive disorders of pregnancy, hemorrhage, infection, and other complications. Mental health outcomes, including anxiety, depression, and trauma, especially after disasters or displacement. There's environmental risks. These are the conditions in the physical environment that shape those outcomes. Things like extreme heat and heat waves, air pollution from traffic, industry, or wildfires, water contamination, so, chemical, microbial, or both, exposure to pesticides, heavy metals, or other disrupting chemicals, flooding, drought, and other climate related events that affect housing, food, safety, and many others. Animal and vector related risks. Here we consider how animals and vectors intersect with pregnancy and child health. Zoonotic infections that can affect pregnancy outcomes, things like mosquito borne diseases like Zika, dengue, and malaria, livestock or animal related exposures in rural or agricultural communities, companion animals and their role in both risk and resilience. For example, mental health benefits versus allergen exposure. Infrastructure and risks, systems risks. Here, finally, we look at the systems that are supposed to support health, things like hospital closures, especially in rural or under resourced areas, transportation barriers that make it hard to reach care, power outages that affect neonatal intensive care units or birthing facilities, supply chain disruptions for medications, formula, or other essential equipment. Emergency response systems that may not prioritize pregnant people or families with young children. But when we put all of those things together, we see that maternal and child health is embedded in a web of ecological and systemic vulnerabilities. A One Health risk analysis doesn't replace traditional MCH approaches, it expands them. It helps us see where interventions might be most powerful, not just at the bedside, but in housing policy, climate adaptation, transportation planning, and disaster preparedness. Again, the image on the left was created by AI to really give us a visual of those points I just described. I want to zoom in specifically on maternal and child health within One Health. Pregnant bodies are uniquely sensitive to environmental stressors. Physiological changes in pregnancy, such as cardiovascular, respiratory, immune, endocrine, can increase vulnerability to heat, air pollution, infections, and toxic exposures. But there's also a social and gender dimension. Women and birthing people often carry disproportionate caregiving responsibilities, especially during crisis. They are the ones figuring out food, water, shelter, and safety for children and elders. In many settings, women are more exposed to certain environmental risks because of gendered roles like agricultural work or water collection or informal labor in hazardous environments. Access to reproductive health services can be disrupted by conflict, displacement, or disasters, with long term consequences for health and autonomy. Reproductive justice frameworks align naturally with One Health. Both insist that health is not just about biology, it's about power, resources, and the right to live in safe, sustainable environments. So when we talk about One Health, maternal and women's health should not be a side note. Children's health, too, should not be a side note. It should be a core consideration. Now, zooming in specifically on children, children are too are at the center of One Health. Children are not just small adults. Their bodies and brains are developing rapidly. They breathe more air per body weight, drink more water, and often closer to the ground where pollutants can concentrate. They are more sensitive to environmental exposures and they live longest with those consequences. Some of the issues emerging in One Health and related research include respiratory illnesses, rising rates of asthma and other respiratory conditions linked to air pollution and wildfire smoke, neurodevelopmental impacts, associations between chemical exposures like lead, pesticides, and endocrine disruptors, and cognitive or behavioral outcomes. Infectious disease vulnerability, climate-driven shifts in vectors and pathogens that increase children's exposure to diseases like malaria or other emerging infections. Food insecurity and malnutrition, ecological degradation, and climate change affecting food systems with direct impacts on child growth and development. Things like heat exposure. Infants and young children are particularly vulnerable to heat stress, both physiologically and because they depend on adults for cooling and hydration. Mental health. Children experiencing displacement, disaster, or chronic instability may face long term psychological and emotional impacts. In many ways, children are ecological indicators. Their health reflects the health of the systems around them. When we see children struggling, it's often a sign that something is deeply off in our environments, in our structures. Here on the slide are just a couple of snapshots of pretty recent research that's emerging focused on children in the field of One Health. So I want to close with a call to action. If we accept that maternal and child health is deeply intertwined with environmental, animal, and systemic factors, then One Health cannot be complete without MCH at its center. So, what it might look like to truly elevate women's and maternal health research within a One Health framework. Here are a few directions. Expand the One Health agenda to explicitly include maternal, reproductive, and child health, not just as vulnerable groups, but as core drivers of population health and resilience. Invest in transdisciplinary research that brings together birth workers, communities, organizations, tribal entities, environmental scientists, clinicians, social scientists, and researchers and policymakers, not just as token collaborators, but as co creators of questions, methods, and solutions. Design climate resilient maternity care systems, ensuring that pregnant people and newborns are prioritized in disaster planning that facilitates and the facilities are prepared for heat, flooding, and power outages, and that community-based care is supported, not just sidelined. Center reproductive justice and One Health, recognizing that the ability to have a child, not to have a child, and raise children in safe, sustainable environments is fundamental to health as a population. Support community knowledge. Doulas, midwives, birth workers, and parents hold critical insights about how systems succeed or fail in real life. Their expertise should shape research, policy, and practice. And for each of us in this Zoom or in this presentation, the question becomes, how can my discipline, my role within One Health, my projects move one step closer to a One Health approach that truly includes maternal and child health? Where can I build bridges across fields, across sectors, across communities? When we center maternal and child health in One Health, we're not just protecting individual pregnancies or childhoods. We're investing in the health of families, communities, and ecosystems for generations. This is not a side project. This is the future of public health and One Health. Thank you so much for being here, and I'd love to hear where you see yourself in this conversation and what possibilities this opens up in your own work. Thank you.